Hello, everyone. Welcome back from our break. My name is Maureen Walton, and I'm the Senior Associate Director of the Injury Prevention Center. And I'm really excited to be here today to MC the remainder of your event. I have the great pleasure of next up, we will hear from Dr. Allison Lin. And Dr. Lin is an addiction psychiatrist and assistant professor and director of the Addiction Psychiatry Fellowship Program at the Department of Psychiatry at the University of Michigan. And she's also a research investigator at the VA Ann Arbor Center for Clinical Management Research. She's also a core research project principal investigator for the U of M Injury Prevention Center, and her research focuses on developing ways to improve quality of care and access to treatment for patients with opioid and other substance use disorders to prevent harmful outcomes, including overdose. Her research also includes a focus on developing telehealth models of care to increase substance use disorder treatment. Remember to type all questions in the Q&A box, and please join me in welcoming Dr. Allison Lin.
Thank you. My name is Dr. Allison Lin, and today I'll be talking about use of telehealth to expand access to substance use disorder treatment and lessons learned from a number of projects during COVID-19. At this point, we know that the overdose epidemic continues in the US, but has shifted dramatically in recent years, shifting away from prescription opioids to focus on people using multiple substances, and in particular, street drugs like heroin and fentanyl, combined with other substances, specifically stimulants and alcohol. And initial estimates from 2020 indicates that overdose rates further increased in the setting of COVID-19, with 20,000 more people who died from overdose in 2020 compared to 2019. Despite the tremendous impacts of addiction on overdose and other negative outcomes and evidence that we have effective treatments that can help reduce overdose risk and other impacts, one of the biggest challenges is the limited access to effective high-quality care in our communities. Although 21 million people in the US have a substance use disorder, only about 10% receive treatment. This is lower than treatment rates for pretty much any other common medical problem, including other mental health conditions. We know there are numerous barriers to care, and I like to think about these under the trifecta of barriers, including those related to stigma, related to the underlying illness and symptoms of addiction that by definition makes it hard for patients to engage in care and makes it so that folks are ambivalent about cutting down their substance use and seeking care. And finally, the accessibility and the way we think about delivering addiction care and the systems that we have in place. According to the National Survey of Drug Use and Health, these all contribute as reasons why patients with substance use disorders have a hard time engaging in treatment. To address these barriers, we have to think about new and different ways to reach and deliver care to this patient population. One of these promising models is through telehealth, and some studies have indicated telehealth can specifically decrease treatment stigma and extend access to care for other chronic conditions. But less is known about telehealth for substance use disorders, so this has been a focus of my research for a number of years. As a clinician, I've also been using telehealth and the Veterans Health Administration to deliver buprenorphine treatment for patients with opioid use disorder for a number of years, and I've seen some of the positive impacts. Telehealth has been a promising option for many years, but then came COVID-19, and this has radically changed the way healthcare is delivered across this country. There have also been numerous key changes in federal regulations and guidelines to make it easier to specifically deliver care for substance use disorders via telehealth. These key changes include the Ryan-Haight Online Pharmacy Act exemption during public health emergencies that allow providers to prescribe controlled medications like buprenorphine for opioid use disorder without an initial in-person visit. In addition, there's been new guidance and changes from SAMHSA, DEA, numerous payers to decrease barriers in the use of phone visits, or specifically to allow phone visits for delivery of buprenorphine treatment. Also increased take-home methadone doses, loosening of CFR 42 Part 2 and HIPAA regulations, and increased reimbursement for telehealth. In our recent work, we're examining the impact of these policy changes and are finding these changes implemented in March of 2020 are associated with significant increase in buprenorphine treatment and improved retention in the setting of a dramatic shift to telehealth. This figure is from an ongoing study we're conducting examining the impact of COVID-19 on care delivery in the Veterans Health Administration for veterans with opioid use disorder. In the figure, the blue line represents in-person visits for buprenorphine. Starting March 2020, you see a major shift away from in-person care to phone visits, represented by the orange line, and video visits, the green line, with phone continuing to exceed video visits by February of 2021. Although COVID has greatly disrupted care across the healthcare system, these results indicate that telehealth has helped to sustain this crucial treatment for veterans with opioid use disorder. A big concern now is as care begins to shift back to in-person treatment due to clinic policies and changing COVID-19 policies. This can really hurt some of our patients, many of whom have now only known buprenorphine treatment via telehealth. In addition to examining treatment utilization, it's also important to understand patient experiences with this newer model of care. In a recent study, we interviewed over 30 patients with opioid and alcohol use disorder to better understand patient experiences with telehealth. We find that experiences vary widely and emphasize that there's not just a one-size-fits-all. It really depends on patient preferences and what the feasible alternatives are for each patient and at each point in their care. Patients described numerous advantages to telehealth, key being a decreased feeling of stigma or being judged for their substance use disorder. However, they also described disadvantages, including a decreased feeling of connection at times with providers. Key ongoing barriers they described remain the logistical challenges, including unreliable internet access and limited resources in this population. So COVID created a natural experiment that none of us would have ever asked for. But when it comes to telehealth in the future, I think what I hope for is the ability for patients and their providers to have options, including in a hybrid model with both in-person and telehealth care, depending on the patient, their circumstances, and their clinical presentation. Despite the promising indicators for acceptability and use of telehealth for substance use disorders in real-world settings, there are a number of likely ongoing barriers to adoption and sustaining telehealth in a post-pandemic era. I've given many talks on telehealth for clinical audiences, and there are key challenges and barriers that clinicians and administrators describe. These include clinician and staff discomfort due to uncertainty about practices. So it's really not just about a shift to telehealth, but there are other practices that change in association, including frequency of urine toxicology screens. Also, they describe challenges adhering to changing federal and state regulations, including on prescribing controlled medications. Also, how to treat more complex patients who may at times need higher level of care, of which access to is also limited. And finally, engaging patients in care, especially those in rural areas or patients with limited access to technology. These barriers have informed recent work I led with the family medicine physician, Chris Frank, to develop a toolkit and guidance funded by SAMHSA through PCSS, the Provider Clinical Support System. This toolkit is geared towards both clinicians and policymakers, summarizing the current state of federal and state regulations on telehealth for opioid use disorder and recommendations to support high-quality telehealth delivered treatment. We also provide tools for clinicians, including alternative options to urine toxicology screens, decision support tools, and a clinical note template to support opioid use disorder treatment beyond COVID-19. This toolkit will be available online in the next couple of weeks. In addition to this pragmatic clinical work, I also strongly believe that additional research is needed to capitalize on telehealth to actually increase treatment for patients with substance use disorders. We cannot just take our in-person care and turn it into telehealth and expect that it will increase treatment utilization. We really need to build new models of care with telehealth as a component. So we've developed a new model of care called InReach, designed to be implemented in healthcare systems to proactively identify, outreach, and help motivate patients for treatment, and then offering them a more patient-centered, accessible treatment option delivered via telehealth to them at home. We're currently testing this model of care in a randomized controlled trial funded by the NIAAA. So that concludes my presentation for today, and I'm happy to take any questions.
Thank you so much, Dr. Lynn, for that great presentation and all your wonderful work on telehealth and substance use disorder treatment. We have a number of questions coming in, but I did want to thank you and say that we have included a link to your toolkit on our Injury Prevention Center website. So thank you for sharing that with us. So my first question has to do with the fact that on one hand, telehealth rates have increased during COVID, but on the other hand, overdose rates still continue to rise. What do you make sense of those two things?
Yeah, I think this is a really important question to ask. And a lot of folks oftentimes will ask me that question, especially in a policy setting. And I think the most important thing that comes back to is one of the initial slides where I showed that the current treatment rates for substance use disorders remains very low, right? This is an area where about 10% of people are receiving care. And I think telehealth has the potential, and what I've shown is that it has sustained a lot of care during COVID-19, which is really, really important because it's sustaining care for the most vulnerable populations where we might have assumed care might have particularly decreased. On the other hand, just delivering care via telehealth, meaning doing the same thing that we were doing in person, changing it to telehealth, which is primarily what we've done during COVID, is not going to reduce that treatment gap, the one where only 10% of people are receiving care. I really, truly believe that in order to actually reduce that treatment gap, in order to decrease overdose rates and other negative outcomes, we really have to think about reaching more people, making care more accessible overall, reducing the stigma of treatment in general. And one of those kind of approaches or proposals is the Enreach program that I mentioned at the end. But really, I think we need a lot more research into how to do that. So how do we deliver care in a way that's different from how we've historically done it in order to reach a much wider patient population who need it?
I mean, that makes a lot of sense. So it sounds like increasing access is really what we need, and telehealth might be one way to do that, but we need some others.
But not just increasing access. So I think one of the challenges with traditional addiction care is even if you have access to it, it's not always the case that folks are going to be interested in going, or it's not just about access to care. The vast majority of people who might need treatment and could benefit from it never are made aware of treatment. So it's not just about access, it's about accessibility and the appeal of treatment, and making it so that it's actually easy for people to engage. This is a condition that's different to any other conditions because by definition, it's a condition where people are going to be ambivalent about treatment. So in order for folks to receive treatment, we really have to think about building treatment in a way that's actually more accessible than probably any other types of illness that we treat.
Yeah, that makes a lot of sense. And it relates to this question that came in. And that is, as hopefully COVID subsides, and obviously COVID has led to a number of policy changes related to telehealth. What is the right mix of telehealth versus in-person care? How do we keep the best parts of telehealth models of care going?
Yeah, I think that's not just $1 million question, that's probably $1 billion question. And we don't know the right mix, right? So we are beginning to get some data just on usage and things like that. But I think what we need to understand is how different people do with telehealth. The clear thing is before COVID, right, the vast majority of people were not receiving telehealth. It wasn't an option. During COVID, honestly, in a lot of clinics and settings, we transitioned almost completely to telehealth. So it was almost not an option to not get telehealth. Hopefully, in a post-pandemic world, we will have a case where both patients and providers will have options, meaning it's going to be related to patient preference, provider preference, and also the clinical needs of that patient, right? And that's why I think it was clear just from those patient interviews, it's really not a one size fits all. So I have some patients clinically who, live 2 hours away from treatment, but still say, oh my gosh, the day I can come and see you in person, I'm going to be there in person. But then I have some patients who live very close by who say, you know what, I love telehealth. I actually don't want to go back to in-person ever. So there's so many different layers, and really we don't have enough data yet to determine actually how patient outcomes vary by which types of modalities they receive. So hopefully, I think as we get more data, we're able to compare patient utilization and outcomes as they use the different modalities I've mentioned.
So that relates to this other question that has just come in. And, what do you see as important innovations then in telehealth? It sounds like there needs to be some matching based on patient preference, but what do you see as something we can do in telehealth to improve it?
Yeah, so I think there's a few things. I think the issue around technology access really persists. So, for example, I work in the VA system where we actually give people free iPads. So my veterans with substance use disorders who oftentimes have lots of, psychosocial challenges, we're actually able to get them access to a certain amount of technology. Even with that said, we're showing kind of in our data that the vast majority of people actually are receiving phone visits. And so, it might be true for other patient populations that video can be very accessible currently, but for our SUD population, I would say that video remains a challenge. So thinking about care delivery in different ways, thinking about getting people more access to video if needed, but also thinking about use of phone or maybe different combinations of technology in a more flexible way. Is it really true that telephone visits are going to be so different from video visits are going to be in person? Maybe, maybe not. But can we design kind of treatment models that are more flexible? And that goes back to my prior point, which is it's not just about telehealth. I mean, telehealth is not rocket science, right? All of us are now familiar with it. The fact that we're doing this conference means that every person here is aware of what telehealth is. But really, it's about, can we use telehealth as a tool, as a new way of thinking about care delivery in order to reach more people, deliver more care, keep people more engaged over long term? Like, those are all unanswered questions, I think.
And we just had another question come in about stigma. What about stigma and telehealth? Have you found individuals with greater self-stigma find telehealth more acceptable?
So I think there's a lot of layers here, and there's actually not a whole lot of literature. So I am hoping that folks out here would be interested in this question. I think there's some early evidence from mostly kind of clinic case descriptions that have come out since COVID, and also a history in the mental health literature that for some folks receiving care via telehealth might feel less stigmatizing. And stigma really is very complicated, right? There's the individual level stigma that prevents people from seeking care because of the stigma that they feel toward their illness, but there's so many other layers at the community level, at the healthcare system level. But one of the things that I found with patients is just the sheer fact of not having to wait in a SUD treatment program waiting room itself, right? Like we really oftentimes minimize how difficult it is and all the little barriers that add up to a ton that it takes for people to be willing to engage in care. So the fact that this illness continues to be stigmatized is something that we need to continue to change. But currently, we can't escape the fact that a lot of folks are going to feel the stigma and the difficulty of actually reaching out for treatment. And so for some people, it's I can receive treatment from the comfort of my own home or anywhere else for that matter, whether or not I could actually continue to go to work, but take like a lunch break or a short break during the day and actually make it to my treatment visit. Those things I think are really both convenient, accessible, and help reduce stigma. The other piece that's kind of a side piece that I think some people might be interested in. I've also been speaking with folks kind of who do a lot of policy around kind of treatment of trauma and things like that. And so there are subpopulations where telehealth might actually be not only less stigmatizing, but help people feel safer in terms of accessing care. And we have to think about some specific issues related to some of these special populations in terms of, it's not just about stigma. It's like, how can we help people feel safe in accessing care that they would have a hard time receiving otherwise?
Well, and that fits well with this next question, which is, how is telehealth approaches, obviously for substance use disorders and to prevent overdose, how can that be applied to other injury prevention areas?
Yeah, I think, like I said, telehealth is just a small, simple tool. And I think that's the whole thing is, 5 or 10 years ago, I had published a systematic review, maybe just a few years ago. And it's clear there's not as much evidence or research studies on telehealth or telemedicine for substance use disorders. But I think with COVID, it's just things have changed so dramatically. I think the questions are less interesting about, is video just as effective as in person? I don't think those are the interesting questions. It's really about how do we think about making care more accessible for different populations? So for example, for overdose prevention, right? We know that the populations of folks who most are in need of kind of the knowledge and the tools related to preventing overdose are not necessarily the ones who are going to access our healthcare systems. And so there's no reason, especially with policy changes and such, that we can't be delivering interventions in lots of different settings. The question is, where do we reach people initially to engage them? But then we can now deliver ongoing interventions, both through video and phone, in many different formats. Pretty much all of the interventions that we think about, we should really think about how to flexibly deliver them best to the populations who really need them.
That makes a lot of sense. And so I want to thank you, Dr. Lynn, for your wonderful presentation today and for that really active Q&A. So people had a lot of great questions for you. So thank you very much.
Thank you. I really enjoyed it.